Good morning, everyone. My name's Liz Kalina, and I head corporate affairs for Ipsen in North America on behalf of all my colleagues. Welcome here today to Healthier Handoffs, Perspectives on Transition of Care. We're so excited to have you here. About 4 million adolescents turn 18 every year, which is, that sounds kind of like a lot of change. One of those changes is moving from pediatric healthcare to adult healthcare. And while we all get older and it's just a normal part of living, this can be really, really overwhelming, and it can also present some gaps in care. And we know from the patient advocates that we work with, they really want better tools to navigate this transition for their young adults. We also see the terrific work that our healthcare providers are doing, many on their own, with structured, organized ways of looking at standardized approaches to help these young adults be as successful as possible. And we are also lucky to hear today from some patients who have recently moved from pediatric care to their own healthcare setting in their adult life. So we'll hear their tips and tricks and some of their watch-outs as well. Everyone's perspective is their own, so no generalizations here. This also isn't a forum for medical advice. So for our folks online who are listening, if you have any questions, certainly ask your doctor first. They can help you the best. All of our panelists today are compensated by Ipsen for their expertise, and we're so appreciative of that expertise. And I am privileged to introduce you to Dr. Gupta, who is a pediatric hepatologist, professor of pediatrics, and transition clinic leader at Emory and Children's Healthcare Atlanta, and she's going to get us started. Thank you.
Good morning, everybody. I think I'd like to call this the successful 5 a.m. breakfast club, so thank you for being here early this morning. I want to start with a little story, and this is a true story. Have you all ever done career days for your elementary school kids? No. So I was doing a career day, and after I finished my doctor thing in the white coat and all, a janitor came up to me, and he said, "Oh, Dr. Gupta." I was like, "Yeah." And he was like, "You know my nephew?" And I was like, "Oh, I do? Who?" And then he said, "So and so." And I was like, "Oh, yeah, how is he doing?" Because he had been transferred to the adult side. And he said, "He just died last week." And I was like, my face fell, all the excitement, and I was like, "Are you kidding? What happened?" Because we had transferred him like maybe a month prior to that meeting, and then yada yada, he said he didn't know, and so that kind of struck a real chord with me, and I'm like, what is going on? And this was way back in 2011, and I was a basic scientist working towards my KOA. And in heart, I'm a clinician. I'm a liver transplant specialist, and I deeply, deeply care about these children. And so we started a transition clinic, and this is like I said, 2011, and we started looking at data on what was happening to our kids who were transitioning to our local centers. So the clinic was started, and the whole focus was on patient and parent perspectives on what they wanted to do, because prior to that, we just had transfer processes. So transition, as you all know, is a process. Transfer is the final transfer which happens when you move from one to the other center. And so anyway, so our clinic got started, and during that time, I had a med student, and with hearing this young man's and this story, I was like, let's see what our kids are doing. And so we started looking at that data. And again, transition clinic, the whole focus was on what we can do for kids. It was not for my career advancement. Because like I said, I was doing bench work as well on the side. So the entire focus of the clinic was on what can we do to make this process better. And during that time, this med student collected data. And when she showed it to me, I was like, wait a minute. That just can't be right. I still remember I was in my office, and she came in, and my lab was right outside, and I had just looked at some other data, and she showed me. I'm like, "Are you sure?" What we really found was there was like a 28% mortality. 28% mortality after transfer. And we all care deeply about our patients. I know that. I know my adult colleagues do. So despite that, we saw 28%, 1 in 4. 1 in 4 patients had died within the first 5 years of transfer, and majority within the first 2 years. And I come from the state of Georgia, and we have an overrepresentation of Black patients, and what we found in this group, majority of the patients were Black. So it was very, very sobering, and once we realized we had that data, which did get published, I reached out to one of my adult colleagues, and I want to really give a shout out to him, Dr. Ryan Ford, who is an adult hepatologist at Emory, and we said, I need your help, we need to do something. So in 2015, we started what we called a joint clinic, so a joint pediatric and adult clinic, where my job is to prepare them from 14 hours. So the way our transition clinic is set up, we start at 14, there's a single MD, so I follow 1/3 of our pediatric transplant population, but I think having the continuity is extremely important. It helps build trust with these young teenagers and young adults. And we are blessed, we are fully resourced. We have a psychologist, we have a child specialist, a school teacher, a dietitian, and nurse practitioners. And it's all started with a grant, actually. There was not much funding for it, so we started with a very generous grant from one of our donors, and then it's taken a life of its own. And we see the kids in this clinic. This replaces their transplant clinic. So again, we don't increase the clinic burden, right? You've got to, all through the process of this clinic, I think I have learned a lot, my team has learned a lot. And one of the things we have learned is you have to find a sweet spot for everything, right? You want to see them, but you can't add to the clinic burdens, right? You want to tell them, but it's not just because I want to speak, so you need to hear me. You can't just keep throwing education at them without realizing what they need or what they are receiving, right? So from 14 to 21, we prepare them. The whole time we are doing education. We are actually also developing a risk assessment score, which I'm hoping I'll have data in the future to show you. But during this time, we also realized that the patients who had died or were lost to follow-up, there were 3 things which were associated, or 3 risk factors which were associated, development of diabetes, which can be rough, substance abuse, and then not graduating high school. And we were like, bam, okay, one thing we can affect. So in our transition clinic, we've really made a big focus on making sure the kids graduate from high school. And if you think about it, graduating from high school, learning responsibility kind of correlates, but this was one thing we felt we could make a difference. This data was also published. And then, so getting back to that joint clinic, which I do with my colleague, Dr. Ford, who also maintains that continuity with these patients. So by now, we've transferred about, I have to say about 130 or 140 young adults to the adult center. And again, we are blessed. So till about a year ago, we are freestanding children's hospital. Our EMRs don't talk to each other, or did not talk to each other till at least about a year ago when they went on Epic as well. But even though we were located in close proximity, there was still a big divide. And so the joint clinic with Dr. Ford, who maintains that continuity, so we see them together in the first year, if possible, which scheduling has become a problem. And then after that, they follow in his clinic. And so we looked at our data again. Hey, what are we doing? Is it just, we are just talking? Are we really making a difference or not? And so once 5 years completed, we looked at our data again. And again, I'm thrilled to share with you, the mortality rate went down to 3%. So from 28%, and it's deep, it's emotional for us, because I think this is what we do. Out of all the things I've done in my career, I think this has been the most gratifying. So the data is written, the manuscript's written, it's still not been published, because guess what? People who are busy actually taking care of patients don't always find time to write. So I know there's a wealth of knowledge which we are going to share with you today from our clinicians and our patients and our social workers who work in this area. So with that, I think I want to move on to the next panel. So the morning is going to be divided. We're going to have 3 panels. We'll talk with the patients. We'll talk the pediatric perspective first, and then Dr. Pratt will lead the adult perspective. So I really look forward to a good engagement session this morning. Alrighty, so with that, I would like to invite Susan, Marissa, and Jordan to come up to the stage. Oh, thank you, yes. Yes, the podium goes away, thank you. That's good. Great, so I'd like to introduce Marissa first. Marissa is a 25-year-old young lady who's living with PFIC and other chronic conditions and was diagnosed in your early 20s, right? After really lifelong health challenges. So thank you for being here. I think your perspective is going to be supremely valuable. Now, Susan is a clinical social worker at Boston Children's Hospital who specializes in transition from pediatric to adult healthcare. So she can give us she'll give us the systems perspective on that. And Jordan, thank you for being here again. President and co-founder of BEAR, which is Biliary Atresia Research and Education Advocacy Organization. Biliary atresia, how many adult providers in the room? Okay, we do have some, okay. The pediatric providers don't need any introduction to biliary atresia. So she's mom to Hudson, a 9-year-old who is post-transplant after being diagnosed with biliary atresia. So we look forward to a great session this morning. Thank you for being here, everybody. Alrighty, so let's see. Marissa, not to put you in the hot spot, but again, I feel what all we do is always patient-centric, right? Mm-hmm. So tell us about your experiences, because you've moved from a pediatric to an adult healthcare system, and what do you think about it?
So it's definitely an interesting transition. I know a lot of people think that once you turn 18, you just have to handle it all yourself. And that's not entirely the case. I still keep my parents involved in my healthcare because we've been at this for almost 20 years at this point, and we're kind of in this together. So they help me with anything with insurance, going to appointments with me, talking about healthcare decisions. So even though I handle most of my own day-to-day life and caregiving, they still help me on my medical journey because they still want to be there and they want to support me, and it doesn't make sense to just, when they want to help, I want them to be involved.
That's a great answer. So when we started in 2011, we focused so much on independence and not getting the parents involved. And this is unpublished data, but we have it. We also have found that parents who stay engaged while empowering the young adults, those are the families which do the best. So thank you for sharing that. Yeah.
Thank you.
That's great. Jordan, you have a really unique perspective because you have a child. Obviously, people know biliary atresia is diagnosed as a baby. So you saw him as a baby. Now he's 9, preteen, maybe 9 going on 15, 20, and then you're heading this organization. So can you tell us a little bit about your experience?
Yeah, first of all, I love what Marissa said in terms of getting your parents involved. I think when I wear the hat as a caregiver, I obviously do want to foster that independence. And however, as a caregiver, I still want to create that relationship where if he needs help, if he needs guidance, he can still come to me and use me as a secondary support for that. But obviously, as we progress in the transition of care, I want him to learn to advocate for himself. I want to give him the tools to be independent and do those day-to-day things like Marissa's talking about. Marissa, when her and I were speaking, I was like, Marissa, you're like my poster child of what I want my son to be. And I think really just a great example of a new dynamic where parents go from being the primary caregiver and making those decisions with the healthcare provider to taking a back seat, and they really need to take on that secondary support system. And I think that by not acknowledging that, I think it sets up this system to not be as successful. And to address that, hey parents, the kids do need to be in the driver's seat for this, and then you need to go into the passenger seat for that.
You know, it's interesting because when we make the shift, so if I do general transplant clinic too, I see them at 12, I'm talking to the parent, and then when they come to our transition clinic, and I'm like, oh no, wait a minute, I'm not supposed to be talking to you. You're still here, but I try to engage the child, a young teen, in that. Yeah. Susan, how do you put this together? Because you're seeing Marissa's perspective, and Jordan just mentioned as a parent, and I see that in my clinic, this dynamic every day, who's talking and who's asking questions. How do you put that together?
I think, well, we heard from the experts, but I think the word acknowledge is incredibly important. So there are things that happen when you turn 18, but that's not when healthcare, everything changes. I think the important pieces are acknowledging what those things are and then talking about them, right? I'm an adult. I might like a secondary caregiver to come with me to a stressful medical appointment, and I am far from a young adult. So I think there's a place for that, and people need to understand there's not like a cliff that they're falling off of. They absolutely should be given the voice to say, actually, I'd like you to back off, mom or dad, or yes, please be part of this conversation. But acknowledging that those changing relationships are happening, both with patients and their providers, and parents and their providers, and also patients and parents themselves, because not every parent is ready to put them in the driver's seat, and I think that there's just a lot of that. But acknowledging that these changes happen, I think, is really the important piece. For some reason, we don't talk about it in healthcare as much as we do with other things. I mean, I think we know some of those reasons are because there are higher stakes, perhaps, of which college to choose versus sort of some of your healthcare things might be a little, you know, the decisions might be weightier. But we're often surprised by leaving a pediatric setting in ways that we aren't surprised by high school graduation or, you know, leaving some pediatric services that we know are ending. So just being explicit about the fact that you're going to move to an adult healthcare provider, as you do with your transition clinic, people know we're in this because we're preparing for something is really important.
Yeah, I think you bring up a very good point. Also, acknowledging and also setting expectations, right? Yes. Setting expectations. And I think I'd like to throw in another word in here, and that is trust. As pediatric providers and the pediatric setup, we have to have trust in our adult colleagues and vice versa. Yeah. And I think that goes a long way as well when we say, hey, you will be fine. You will be fine, and this is what we are going to prepare you towards. Of course, easier for me to say that because I do explicitly trust my adult colleague again, but I think that also becomes very important. So Jordan, I think I can safely ask you this question, and I can do that because I'm a mom too, and I'm asking a mom. How do the providers work with, tiger moms? No offense here, but and I'm sure I am one of those, But if we see, how do we handle? How do you, and Marissa, please chime in as well. That how do we handle that dynamic in clinic? What should the pediatric providers be doing?
Well, I love that you mentioned trust, like one of the words you were saying, trust. And I think that there also needs to be that relationship between the parent and the provider, where there needs to be trust that we're doing the things at home. So talking about transition of care before transition of care actually starts happening. Like, we don't want all of a sudden kids turning 14 and being like, oh, now we have to start transition of care. Like, these are things that we can do early on. Obviously age appropriate. We can go ahead, if at 6 years old, they're not going to know the names of the medications that they take. But, like, for example, what I've done with Hudson is he knows that his yellow pill is his liver pill. He knows that, his red pill is his iron, and, which is like my blood pill. So he knows, like, those types of things. Obviously, that gets more sophisticated as they get older. So the provider needs to know that or trust that the parent is doing that on their end. Now, from the parent side, we need to trust that the provider has seen this and that they know and have the best interest of not just the child, but the family dynamic. Because as you mentioned, in your opening, having that support system is an indicator of success later on. So I think really that trust that you mentioned, I keep going back to that because I think that is really important. within that pediatric space, because there is that third person, which is, I like to say passionate mom, not tiger mom. So that passionate individual.
Yes, you used a better word than I did. Marissa, have you had that? Have you had to navigate that with your parent and your provider? And what advice would you give for everybody how best to do it?
So I would agree that like trust is so important, and I wouldn't really say like they're tiger parents or anything. They're just more involved because they want to be and they care. But that trust between the parent and the provider, and just the trust in like general, is so important, because I notice like a lot of adult providers don't really foster that. They just kind of like focus on just the patient. So it's really important to like, if they have like a parent that wants to be involved, make sure they're involved too, but not to the point of like overshadowing anybody, but just make sure you include the whole support system as well. And I've had pediatric doctors do that really well, just including everyone, but that transition just doesn't happen, and you get just the one person handling it. That's how you get the one person just handling it, and everyone else feels left out, even though they also attend the appointments.
Yeah. No, I think you said it really well. We try, and I'm sure, Susan, is this kind of been your experience as well?
So I think we sometimes sort of do this family-centered, wonderful pediatric thing versus an adult patient-centered, and we think of it as this, we need to set the expectations, and young people need to understand when they go, they're going to speak to you, et cetera. If we do a good job of it, while we're doing the whole team-based approach, the young person still is put at the center of it, and they've been practicing those things to the level that they can, right? We have kids who are developmentally across the spectrum, so they perhaps aren't going to be able to do it at all, and the adult providers can have an understanding of when to let folks in. But there's also a flip side of it that's incredibly empowering for the teens to know, oh, when I get there, I'm going to be in charge, and I'm going to say who I want to pull in. So I like to sort of think of it as, as an opportunity for self-advocacy, which if you haven't practiced is going to be really hard.
Yeah, and I think I see that exactly in my clinic. And again, when I was, so yes, the parents need to support, but too much support can be also crippling for the child. So we have to give them space and room to grow as well. So it's finding that Goldilocks status, which is different for each child. So I think that's another one of the things I would like to emphasize. One size really does not fit all. And we talk about readiness, we talk about questionnaires, we talk about surveys. Who all have more than one children, right? Are they all alike? They're absolutely not, right? So when our kids with the same genetic code, more or less, have their own different genes, no child is alike. So how we find that balance in clinic and how we set expectations for what our adult colleagues do, because again, I always also give my team and patients the perspective. We are a high volume liver transplant center at Emory, and we do about 30, 35. We've hit 40 occasionally, and that's really high volume. So top pediatric centers are like 40, 45 a year. And our adult center does about 200 transplants a year. So we have to understand where we are and how we advocate for ourselves. So like to Susan's point, if we prepare them, by the time you're at the adult center, I think it becomes much easier. So it's a lot about preparation, but of course we will hear the adult view as well shortly. So Marissa, how did you build the skills that because can you give us some practical pointers? Like how did you actually build these skills? And then we'll ask Jordan as well.
So it happened like a gradual over time. My parents always involved me, told me what this medication does and what it's called. After a while, I would handle all of my medication taking without any input from anybody else. And then over time, it became my insulin. I would give it to myself. And then over time, it became like speaking up at appointments and advocating for myself and running the appointment. So it was just a gradual over time and just not sugarcoating anything, if that makes sense. Just letting your child know, even if it has to be age appropriate, like what your medical condition involves and how to manage it and how to treat it. It can't just happen overnight, or you can't just shelter them from it, because they are going to have to start handling it one day.
Yeah, so we do need the transition, not just the transfer. Jordan, how would you, I liked your ideas about the color coding and the age appropriate. So what are your plans for after now? Like once Hudson's 10, 11, 12, 14?
Well, I mean, I think I'm taking the same approach that Marissa is taking, where the end goal, yes, is a transition or a transfer. But I mean, I'm not waking up tomorrow trying to run a marathon, right? You have to go gradually. You have to train for that. So that's kind of the approach that we're taking based on where he is. We can go to the next step of like, he just had labs done last week. So I let him choose the arm. He got to choose where he sat. So empowering him to make those decisions, that's really my approach right now, to have ownership of that experience.
Yeah, I think one of the words which I use in clinic a lot is empowerment. And we had published a paper about that when we started a teen camp, where the whole thing was about educating but empowering them to make choices. And they start with small choices, right? You start with small choices and then you include them in the larger discussion. So, well.
Add one quick thing,
yes.
is that it's not just the parent to do it, but also pediatric providers really need to do. Sometimes the teen will come in, headphones on, they'll do the whole visit with the parent. So just to say that everyone really has a part in doing that, and you can, ask the 4-year-old in the visit and the 9-year-old and the 20-year-old, whatever they can answer, and again, pull in additional history. But if you don't, both parents and providers can really push each other in sort of that scaffolding to set the patient up for success, to really, what's the next thing we're going to be working on? What's our next, between now and the next visit, what's that going to look like? But I think it just to call out that providers have a stake in that as well.
Yes, well said, because I think that becomes very important. Like I said, I start talking to the parent because I've known them since the last 14 years, and then I have to oh no, never mind, let me shift to the patient. So very well said. Well, with that, we will conclude our panel 1. Thank you very much, and I'd like to invite Dr. Pratt on stage now. Well, welcome, Dr. Pratt. Dr. Pratt is an adult hepatologist and assistant professor of, I was about to say pediatrics, assistant professor of medicine, and he's the clinical director of Autoimmune and Cholestatic liver disease program. Welcome to this morning.
Thank you.
Yes, I think this is what we need. We all need a seat at the table, at the same table where adult and pediatric providers are talking. But I'm going to start again with you, Susan, here, okay? So, I'm sorry, you're at Mass General, right?
Right.
So, Susan, tell us, what issues do you see across the system? Because now I think with us here, we are going to focus a little bit more on the system, right? What issues do you see across the system?
None, it's perfect. Well, let me say, it happens to be, here we are, and we live in the same city, and we work in systems that are like yours, physically near each other, but not connected. Interestingly, also connect our medical records around a year ago, so this is all happening. I just want to say that speaking with colleagues nationally, even internationally, what's happening in Canada, Switzerland, all of the places, we all run into the same things. Even within institutions, people will find that our pediatric patients struggle. There are the gaps that you talk about, all of those things within institutions. So it's a remarkable thing. I don't know what to do with that quite, except that if we focus on it more and really think about what exists in the systems we have, there are some things that need to probably change in some of those, but also what we can do within what we have is really helpful. So,
Dr. Pratt, let's have your take on this whole thing, okay? Let's have your take on what we talked about in the first session with the patients and the systems. What do you see in your clinic?
Yeah, I mean, I'd like to think about this in a couple of ways. The first is hearing Marissa's wonderful perspective. What we see on the adult side is highly variable in terms of the patients who come to us. And I was going to give you a sense of the spectrum of patients who are transitioning from PD to adult into my practice just in the last couple of weeks to highlight the two ends of the spectrum. At one end, I'd have a 21-year-old who comes to their first adult visit by themselves. They know everything about their disease, they know everything about their treatments and are compliant. And in fact, they want to discuss the pathophysiology of their disease and what sort of research we're doing to try to figure out the disease. And then at the other end of the spectrum, I have a 25-year-old recently who came with their parents, which is great. I'm ready and willing to have a team approach. But they weren't at all engaged in the process. They didn't really want to talk about the disease, their symptoms, their medicines. And so there's such amazing variability. Yes. And so from the adult side, we're always wondering, and I'd love to hear this, how is that final decision made that we're going to send this patient now into the adult clinic? Because it is such a huge transition. And that's a little bit off what you're asking, Nitika, but this is, to me, really important because as we think about how to make that transition successfully, it's a little bit of a black box on our side, knowing what you guys are thinking and how you reach that point in final decision.
Yeah, I think that's a great point of discussion. Susan, how do you make that decision? And I'll tell you about how we've done it in our clinic over these years.
So I have the privilege of working with multiple teams, all making this decision, sometimes different decisions for the same patient. So one thing is just trying to get everybody on the same page and try to think through what they might need. I would say there's variability in your adult patients likely also. Oh. Your 65-year-old who does all the things and the one who isn't on board and all of those pieces. So what I want to, we talk about transition readiness and sort of assessing. I don't think there's like a perfect readiness score. I think when we do sort of transition readiness assessment, we might want to say they're an adult at this point and age-appropriate care belongs, that may be guided by age, perhaps because we're not, our pediatric gastroenterologists are going to miss something if they don't send it over. But I love the idea that if we do some transition readiness assessment, which often is around, I know how to do this, or I'd like to learn to do this, that we just all know what that is. Like this young person you assessed appropriately, the 21-year-old knows a lot of what there might be. They've got the skills kind of down. And the one who isn't quite there yet, what have we been working on, and can we share that and sort of say, this is the struggle realistically, what does that look like? I do think that having some sort of age guideline is appropriate, even if we never have them leave this program that takes care of some, congenital condition, but just for the clarity of it so that patients aren't worrying about when is this happening, why has no one mentioned it? So that I feel like it's important to have some explicit guidelines around.
Yeah, so and there's a lot of debate and discussion on exactly the question you've asked, even amongst our all pediatric centers. And we do all have different opinions as well. So, and I'm welcoming of all different opinions, and I'll give you my perspective. But I actually agree with you, Susan. And I came to that because I was just thrown into it. So when we did start the program around the same time, our hospital decided that we would have a cutoff age of 21, and that everybody needed to go. So there were all these questions which arose: readiness, is a child ready? They don't know their things. Is this right? The brain development, we've talked about that at different forums, right? Like, there can be a delay in development, especially with chronic diseases, and the brain doesn't fully develop till like 24, 25, right? So there was a lot of discussion about that, but it was really not up to me to decide. I was just given a mandate. But it actually worked in our favor because it was setting expectations. And we set expectations. Hey guys, sorry, the hospital wants us to transfer you at 21, so we're going to work towards that.
Yeah.
And we're going to work towards it. And that actually, in hindsight, was very helpful for our program and our setup because they knew it was coming. It wasn't a surprise. And it didn't matter. We don't do a whole lot of readiness assessments, but what we are doing is we are having the same team follow them. So when we bring them to you, we do say that these are the areas which need to be worked on. These are the deficiencies. This one scored, a 4 in AP Lang, but a 2 in AP Physics, right? But they still all go to college. right? So that's how we address it with my adult colleague, and Dr. Ford, as I had mentioned. But setting an age was one of the most helpful things we did. So we transfer everybody by 21, and some may be more prepared than others. And it again comes back to like, all patients are different. We are all different. My husband, who's a non-medical's capacity for handling medical things is very, very minimal. So I have to be there for him. But my capacity for handling engineering things is zero, right? So I think that's where the dialogue is so important.
Right.
This connection is so important that we discuss not only with our patients and parents, but also with our adult colleagues and keep them.
Yeah, I mean, I'll make the point, if I could, that when I think of a successful transition, there are several components of it. The first is the trust component that we heard of. And I have one opportunity to have that initial visit. And so it has to be successful. And the first part of that is really having a complete understanding of the patient's medical journey. I need to know everything about where they've been and where we're trying to go. And so that sort of communication from a medical point of view is so important. So a really good summary of a patient's history is essential. And we'll take the time to really understand that before they come. The social piece is really remarkable. I need to know who this person is. Where are they in their life in general? Where are they educationally? Where are they in terms of family dynamics? Are there issues with substance disorder? Are there other things there that are important, so that on a personal level we can connect very quickly, because they can say, yeah, well, this person knows who I am, knows what's important to me. And then the third part, where I always appreciate a phone call, is if there are particularly potential third rail social issues there that could really derail a first visit if we were unaware of them and suddenly say the wrong thing. That deserves a phone call from the pediatricians. So the way I look at it is, we're ready to handle any of the variability in terms of where the patient is in their preparation, whether it's going to include the parents, whatever that support system they have is in place. But I don't always know until I walk through that door.
Yeah.
Am I going to have child alone, well, young adult alone, young adult with parents, young adult with larger support teams? I mean, it's really can be completely different. But boy, I need to be ready. Yeah. I need to be ready when that time comes, and I need to have the time to be able to help each patient.
Yeah, and not with those 200 pages of medical records to go through, right? For you. Yeah.
Preferably not.
Yeah, I think the systems factors play such an important role when it comes to our responsibilities. So our responsibility is not just preparing, but also communicating, but your responsibilities in terms of receiving and being open to spending the time and with that patient. So the last few minutes, I want to talk about. I say we are blessed, we are lucky. I have a team I work with who's fantastic, so I want to give them kudos for whatever work we've done. It's not one person ever, it takes a team. And sometimes the hospitals and resources don't have a bridges program, don't have you, Susan, as a point person. And the adult centers don't have all the resources we talk about. Oh, I have social worker, I have this, they don't have that. What advice can we give them or to make this transition seamless if we don't have all these roles and low resources? What would be the key?
Oh, gosh. Okay. I mean, first of all, it is an absolute pleasure to hear you speak, because all the time I'm hearing from, there are no adult doctors who want to do this. Yes, there are. I've met them. They absolutely want to do it. And they might lack the resources. I think that's the thing. They might not have time for the extra visit. They might not have a team, as you mentioned. There's not a social worker to call on or a psychologist that's part of the group. And so, taking those phone calls in the team. So we can make it easier, I think. When we do a medical summary in our program, it has all the important medical information. And now, again, you could also pull their medical record much more seamlessly than the previous 20 binders that came in with people. But we have in that very specifically, they're co-created with our patients and or families if the patient is developmentally really not able to do it. And we put on there very specifically, these are the things to know about me, right? They add those pieces. But I think you bring out the important piece of just create whatever the communication, whatever the resource looks like, right? So it's not an extra burden that if you're open to that phone call or you want to get the message or you have the summary, knowing what that is. And part of the expectation setting also is to know how many patients we're asking you to take, right? Like, I think there is a piece of just understanding the numbers. This is how many are seen in our clinic, and this number are this age, and we're hoping you'll take them. Is that 3 a year or 3 a month? And how can we build, really workflows that address all the things you need while getting the patients, what they need.
Yeah, I think that's a perfect point, Susan, that's where we haven't really established that piece as well as we could. I mean, all the amazing research and data you've produced, Tika, does not include sort of how successful are we in this last kind of step of I know you have a transition clinic, but how about all those places that aren't blessed to have just internal, I know not quite internal, but how do we do that? Coming across town from Boston Children's to Mass General, that's a big step. That's
Even
a big
next
step.
door is very hard.
To the Brigham, right.
I think there also is a piece that is, it can't be dependent on one person. I mean, you've spoken about your team and the other team and sort of building that so it's not just one person said they'd take our patients, flood. It's, that's not going to be tenable either. So again, understanding the systems and the programs in which we work. It's a program I work with, and they made outreach to 3 different adult hospitals. How does the intake work? It's very different for each one. In this program, each provider wants to hear directly and have a personal handoff. In this one, they have a scheduler who knows exactly what everybody does, puts everybody in the right place, gathers the information for them, but it's taking the time to sit and say, what does it look like for you as you're receiving this patient? Maybe we were sending you useless information and you wanted something different. Maybe there's someone who does help in your system. There isn't a social worker, but your scheduler runs everything. There's to really understand what everybody's up against is so important.
Yeah. And I think another point you mentioned, which I would like to highlight. So yes, and the reason, that's exactly the reason I wanted to have this discussion, because we can still do it with low resources. And so trust is my keyword, empowerment is my keyword, and my last keyword is care. You care, and you made the point that I want to take the time to get to know my patient. And I think that's where it comes from. So the adult providers, I sometimes can feel overwhelmed with like 20 years of history. Right. So like Susan said, we can make it easier, even at an individual level, to have a clear summary of communication. We can make it easier by that one phone call or saying, hey, I can be reached at, or please call me on my cell. We all use our cell phones, So please call me, so we can do that. And I feel from your side, so whether we send that everybody to one provider, which has been great, but we don't always have that luxury. But if we do send it to a different provider, the receiving provider, when they know that they have a young adult transitioning or transferring to their center, our systems can help us set up perhaps more time. Maybe that appointment needs to be an hour long instead of the 15-minute slots we are supposed to, see our patients with. So again, the point being that even with low resource setting, we can still help the parents, the patient, the pediatric provider, any healthcare navigator, person who can help. If not, then the adult providers are ready to receive, an individual patient. So this can be done. So empower, trust, and care about that. Well, thank you. With that, we will conclude our second panel, and I will hand it over to Dr. Pratt to get the adult view.
Thank you, Nitika. Thank you. All right, so we'll have our third panel now, and I'm delighted to welcome to the stage Nicola and Amber. So as they're coming up, I'll tell you a little bit about them. Nicola is the mother of 2 boys, ages 8 and 12, were upstairs watching with plates of pancakes, we're told. And Nicola was diagnosed with primary sclerosis and cholangitis in her early 20s, and she actually underwent a living donor liver transplant about 16 years ago. In addition to issues related to her transplant, she is also now living with other chronic conditions. And Amber is the mother of 3 children, a 5-year-old and 3-year-old twins. Tired just thinking about it. Amber was diagnosed with PBC, primary biliary cholangitis, in her early 30s. Is also living with other chronic conditions. So they have a perspective which is also particularly meaningful, and really happy that both of you are willing to come and share those. So let me start by saying both of you were diagnosed with rare liver conditions, in young adulthood. So a little different story than what we've been talking about, where we've been talking about PD to adult transitions. Both of you have had the perspective of saying, I've had adult transition sort of thing. So, how was that? I mean, you're having these rare diagnoses, and how did you cope? What was that like for you? And Amber, I'll have you start, and then I'll...
Mine was really awful, honestly. I grew up in what I would generously call a very medically skeptic family. So I didn't have the benefit of having parents that had taught me how to talk to my doctors. We didn't even go to doctors very often. So I had just barely been able to talk to my doctors just as my primary doctors of normal visits when I was initially diagnosed. And so I suddenly went from trying to deal with the transition of having a primary provider, and then all of a sudden I had to have specialists, and I had to have multiple specialists, and that was extremely overwhelming. And very quickly after I finally got settled with having multiple specialists, I was feeling really good about it. I felt really supported by my team. I felt really seen by my team. I got pregnant with the twins. Unfortunately, I was at that time working, and both me and my husband were working. My husband was making more money, but I was the primary holder of our insurance. And when the twins came, there was no daycare in the area that would take 2 twins on oxygen. So I made the decision to stay home, which meant we lost my insurance, which suddenly meant we had to change all of our doctors. So I had this team that I felt really good, I felt really comfortable with. And all of a sudden I had to change all of my doctors and all of my treatment. And we had all of our notes, and we had all of my diagnoses, and we had to have all these new specialists. And all of a sudden we had to go through all of this all over again. And it was just a very big running through all of these hoops and rigmarole and retelling the story and redoing things and not being believed. And it was just a crazy thing to have to go through, and it was a very steep learning curve of how to really advocate for myself, and how to talk about my diagnoses, and how to talk about my illnesses, and how to really come into a transition that I didn't choose. Like, you hear a lot about how people break up with their doctors, they choose to leave a doctor, where I was very happy with my original team, but because of insurance switches, I didn't really get a choice to switch that team. So that was something where I had to learn, oh man, I really needed to have those skills, and I'm very jealous of the kids who grew up with those skills. That was an important thing for me to have learned.
Perfect. Go ahead.
Yeah, I think being diagnosed at 21, you're technically an adult, right, at 21, but you're really still fine-tuning those adult coping skills. And so when I was diagnosed having no previous health issues, it's overwhelming. And you kind of go to the first appointment, and I brought my parents because I was still learning and still trying to figure out how to navigate the system. And as you go through care, I transitioned nicely from bringing my parents to then bringing my fiance, who then became my husband. And now I'm actually at the phase where you become more confident in your health journey, and you go to the appointments by yourself. And I think it's the transition from learning how to dive into the health system to then being able to handle it all on your own. It's something that you just have to learn, and there's multiple coping skills that Amber had mentioned that I think help you get there.
Great. Let me ask you, Amber, and I want you to weigh in too, Nicola. You made the point that you loved your first team.
Yeah.
How did you build your first team? You know, what is the advice you give to people to say, you know, how did you go about that? Because you have rare condition, right?
Right.
How do you find that support for something which is uncommon?
So for the first team that I built, a lot of it had to do with finding people who would listen to me and who were curious. That's been true even as I've now gotten better at building this, second team, and we're getting better at building this second team, and it's become less and less overwhelming, is going into these appointments, being able to say, like, okay, at every appointment there are two experts in the room, right? There's the doctor, you are the expert as, general medicine or gynecology or hepatology, like you are the expert in that field. The patient is the expert in living in the body that they're in. They are the expert in the way that they feel, right? And that experience is being able to bring those two expertness together and talking about that. So like having this experience of even just small things, like coming into an appointment, and everybody knows that, exercise is good. Exercise is good, it helps almost every condition. And the difference between going into an appointment and a doctor saying, something that will help you is getting more exercise. Or a doctor saying, what kind of exercise do you do? That can make a huge difference between feeling not heard, not having assumptions made about you, or having a doctor being able to start a conversation with you and having that doctor making a plan with you, like the doctor that asked me that question. And we made a plan of, oh, hey, it turns out that I was exercising sporadically, trying to make that work, but not actually doing consistent working out. And now I make sure that I get like 6,000 steps a day, working that out together because he was curious instead of telling me what to do. And so always going into that, making sure that I take good notes about myself and making sure that I don't just rely on the notes that the doctors have in their own systems as well. That was a tip that I got from another PBCer, was always come in with your own notes as a patient.
So the sense of a team, right? This is a team. This
Absolutely.
Isn't a rep. So.
Yeah, I think that's a huge part for my life, particularly with when you have a complicated medical case, you have multiple specialists, and unfortunately or fortunately, as a patient, you become the connective tissue between all of those doctors, right? So I'm fortunate to have an anchor on my team who I can bounce ideas off of or just kind of have a conversation with, because all the specialists aren't going to know everything about all of the conditions that you have. So I think as a patient, I've found myself kind of being the liaison, and from a patient's perspective, I would encourage physicians to be medically curious and ask the questions that they might not know something about. So my rheumatologist might not know everything about a liver disease, and I really appreciate the conversation when they come to me and say, hey, can you inform me, help me educate me about this particular case? And I feel like it's rare to find a physician that's willing to learn from the patient too, and I've been lucky enough to have a few of those physicians that have been able to do that for me.
Yeah, I mean, I think I've certainly learned a lot from my patients.
Yeah.
So I think you have to listen, right, in order to have that. Advice, you guys have both made successful transitions through adulthood. What was the success? Was it just perseverance? What is the key to getting through these transitions? What?
I think for me, I can start off with saying that I echo Amber's point about having the notes. I have an extensive medical journal that I've kind of transitioned from my parents to my fiance to my husband to me, and I always take lots of notes, so if something were to happen, it would be an easy handoff to someone to just kind of read up on. I also think it's self-advocacy is a really important skill that we don't always learn great as a child, and so I found myself as an adult, really, if I'm not satisfied with something, to go back, or maybe the physician's not a great fit, and that's okay to find, it might not be a great fit, so maybe find somebody else that would be a better fit for your care. And I think those things combined with a good support system at home, I think has really been nice in helping the transition for me.
I would echo the support system. I think I didn't really get into self-advocacy and really going into, I could get better care. I really could get a better doctor system. I could lean on my support system more if it wasn't for other people with PBC, other people with endometriosis, other people with the conditions that I had, who I could have conversations with who went, that's not how your doctor should treat you. Or, no, actually, you shouldn't be just living with that symptom. You should talk to your doctor about that. It might not have been my doctor's fault. I might have just not been talking about it because I didn't think I deserved care for that. And having other patients say, no, you do deserve care for that. So having that support system, whether it's other patients, whether like you as a provider or a physician can be that, support for your patients, whether that's your family, that having a good support system is really huge.
Mm-hmm.
Yeah. You're both mothers, so I'd love to hear your perspectives as you now are raising your children. How are lessons you've learned, are you passing these on to the kids? How does your journeys potentially impact their journey?
I think for me personally, having 2 boys at home, teaching them how to go to a doctor's appointment and be prepared. So even if it's just a well visit, you check yourself in. You're only 6, but you can go up to the front desk and say your name and your date of birth, and trying to encourage the doctors to speak to them and have the parents kind of fill in the gaps where needed, I think has been a big part for us. And then I also think just them learning to be a little bit more empathetic to those that might have health issues. So some patients with liver disease, when they're first diagnosed, may look normal, and they're not normal inside. And I think it's been really nice for my boys to see that somebody may look normal on the outside, but it's struggling on the inside. So we all know kindness matters. And so I think they've really learned a little bit more empathy from watching mom go through some of the health challenges that I've gone through. And I'm hopeful that when they encounter someone with like situations, that they're a little bit more open-minded and empathetic.
Absolutely agreed. I don't hide anything about my health stuff from my kids as well, and it is interesting to watch the way that they respond to people, like even their friends on sick days, because they've been able to see what mom is like when she has her sick days. And the same thing when they're going to their well checks. Like it is amazing how much you can empower a 5-year-old and a 3-year-old just as much to just say hi to the doctor, just to be able to like encourage the consent, to encourage them being able to say yes, no, especially coming from a background where I wasn't encouraged to go to the doctor. I didn't have that experience. Really, it is really important from that background to me to be like, no, this is important. I want you to feel comfortable to go to the doctor. I want you to feel comfortable to advocate for yourself, and to know that you can go to the doctor as often as you need.
Wonderful. All right, so now as we're wrapping up, I want you both to say, is there something you've been dying to say to clinicians? What can we do better? Now's your chance.
That's a loaded question. I think just from my perspective, having an open conversation with the patient and admitting that if it's an area that you're not a specialist on, to take the chance to be educated by the patient. Most of the patients have read up on their situation and have done the research. I call myself a medical hobbyist. I love to read medical journals in my free time, so I'm probably a physician's worst nightmare, but I would encourage the physicians to just ask the patients if it's a particular scenario where they might not be as informed, to just have a conversation and try and learn a little bit from the patient.
Yeah. And please be curious and give a little grace. You don't know where we're necessarily coming from, whether we want to be there, we didn't want to be there, we have no idea what we're talking about, or we've been doing this for a long time and we're tired. We also don't know where you're coming from, but so a little grace goes a long way.
Mm-hmm.
Wonderful. Well, I really want to thank both of you. That was really wonderful.
Thank
and
you.
Appreciate your perspectives and your willingness to share them.
We appreciate you.
All right, so we'll wrap up panel 3.
Great.
Thank you, guys. And I'd like to introduce David. He's going to come up and have some closing remarks. Ipsen.